Hello, and welcome to Interventional Mindset. I'm thrilled to have Dr. David Goldman of Palm Beach Gardens' own Goldman Eye. How are you doing, David?
I'm great, thank you.
I'm excited to have you here. Just maybe a few weeks ago, you and I were giving talks together. I think I was talking a little about the cornea. You were telling everyone about glaucoma,
I
and
loved it.
it's just what this is about: stretching out of your area of training and bringing all these things into our practice. And so specifically, I wanted to ask you a little bit about incorporating different types of glaucoma surgery, MIGS, and maybe a little beyond MIGS plus into your practice. And first of all, give me the background. I mean, you're a cornea trained specialist. You do a lot of premium. Tell me about your practice.
Sure. So, first I was at Bascom Palmer after finishing my training for about 6 years on faculty. And when I started my own practice, it was focused mostly comprehensive ophthalmology, but with a focus on cornea external disease. So I did a lot of transplants, DSEC, DMAC, or PK, I should say, um, LASIK, cataract surgery, refractive cataract surgery, and anterior segment reconstruction with just a little bit of glaucoma. And over the time, it's actually become less cornea, especially now that I brought on my fantastic partner, Mark Milner, who's just an exceptional cornea surgeon. He's doing the lion's share of the cornea work now, and I'm actually doing probably more glaucoma surgery than I am cornea surgery at this point, but still with a primary focus on cataract.
That's fascinating. So Milner probably does a lot of dry eye intervention.
Absolutely. In fact, he's one of the only people I know that truly loves managing dry eye, and is happy to do it. And I'm happy to refer him those patients.
I think dry eye becomes more fun if you actually treat it than if you just watch it, listen to patients complain, and then don't make them happy. So maybe he's got it right.
Yeah, no, he's had some huge saves and a lot of very happy patients. So it's been a real home run getting him on board and having him join me.
Great. And then okay, and then you're cataract keratorefractive, and then you left Bascom Palmer, you went into your own private practice. And is that when you started incorporating more and more glaucoma?
To some extent, people had told me before when I left that I'd end up seeing more and more glaucoma just because those patients need to come back more often than your traditional cataract or cornea patients. And that turned out to be true. And in my area, there's not a ton of glaucoma surgeons, and those that are there are already very inundated. So if someone comes in with an elevated pressure, it can actually be a little bit of a challenge to get them referred. So the ability to intervene on my own was an advantage for that. Also, patients, once they develop a rapport with their physician, they want them doing their surgery. I've had a lot of, retinal patients come to me, oh, can't you do my injections, or can't you do my, laser of my tear? And I tell them, no, this isn't what I do. But to be able to tell them that you can do things, they already have that confidence with you, adds a lot. It was actually a colleague of mine, and yours, Jay Parek, who initially told me that I was doing my patients a disservice by not offering them MIGs at the time of cataract surgery. And I was coming from a mindset in academics where cornea people did cornea surgery, glaucoma people did glaucoma surgery, and you did not cross the lines. I think that's gotten better, but certainly in private practice, we've blurred the lines a lot. And that really resonated when Jay said that to me. And so I started to delve into it more and began first with iStent and ECP, and then subsequently took on KDB blade and just about every other iteration of a MIGS procedure that came out. I became much more excited about and started utilizing them more in my practice.
So yeah, so you're serving your patients by providing a service, and I have to say, as a glaucoma specialist, I think people are always worried. Well, the glaucoma doc will get mad at me. No, I want you doing the MIGS. Certainly, if you're taking the cataract out anyway, why would we want a patient not to have what's the best in class treatment? And so that's one myth I get rid of, right? And I do some retinal injections, and I always talk to the retina specialists in my areas, and I work within parameters that we all find acceptable. But I think there's a lot more of acceptance of these comfortable small steps out. So I applaud you for taking that step. And so you've moved beyond though just the initial eye stint. Was that how did you come about doing that?
Well, the reps had approached me in the past, and for the most part, I kind of pushed them aside and said, I'm really busy, I don't have time for this. And then eventually, after speaking to Jay and other people as well, they said, look, you're a good surgeon, this isn't about doing a fellowship. If you've got good hands, you know how to do gonioscopy, you can do this. It's not hard. Um, and you'll benefit your patients. And so slowly but surely, after the Glaukos rep, I moved on to other areas as well. I've done Hydrus, I did CyPass, I've done Zen, I've done KDB, I've done Omni, and they all have their pros and cons. But at the end of the day, the majority of them, especially if you're doing them at the time of cataract surgery, in my opinion, don't significantly increase the risks of the procedure that are inherent. But you can really get a nice benefit. And while in the past I've had experience with happy patients with refractive correction, it actually pales in comparison to the glaucoma patients who are able to get off their drops. They are by far some of the happiest patients. And although we talk about drops being the least invasive intervention, I see tons of patients with severe ocular surface disease, meibomian gland damage, et cetera, from chronic use of glaucoma drops. So, while surgery gets a bad rap sometimes, I think we're probably going to move towards glaucoma being treated more as a surgical than pharmaceutical medical disease as well.
Mhm. And I'm sure you find there are benefits for the healing after cataract surgery, whether you're offering premium, upgrades or not, for getting the patients off drops.
Oh, absolutely. I mean, again, we're talking about surgery that oftentimes can exacerbate underlying dry eye or blepharitis. If you can remove some of the factors that contribute to it, it's going to
Mhm.
lead to a more comfortable, happier patient. They're going to have better quality vision with a better optimized tear film. And I think that's where you start to see the worlds of glaucoma and cornea combine. I know we recently were discussing Durista together. And I definitely feel that that's something that, you save the ocular surface with, rather than putting that BAK containing medication that can cause ocular surface disease, breakup, tear film breakup time, et cetera. By putting in the anterior chamber, you're really minimizing ocular surface disease. And that's sort of one small example, but a very pertinent example of how a medication can affect the ocular surface and how we can use our technology to mitigate that now.
It's interesting because I'll often be speaking with reps for some of these companies, and they'll say, well, that doctor, has a lot of premium patients and really doesn't want the MIGs interfering with their premium outcomes. But it sounds like your experience is that it's more likely to help them, right?
Yeah, I think that's a big myth, a misconception too, that a lot of people have, that if you do, let's say, an iStent or an Omni, that you're gonna decrease satisfaction after surgery. You're somehow going to slow down the recovery of that premium lens patient. And the reality is, if you're competent and confident, you know what you're doing, the added risk is very, very minimal. And the reality is, by getting someone out of glasses, but on top of that, lowering their ocular pressure, you're only going to have increased patient satisfaction.
And stepping aside a little bit, but I think it's important, on the topic of offering premium IOLs to patients who have mild or moderate glaucoma, well controlled, maybe they're on one drop, you're trying to get them on no drops with the MIGs. How do you feel about offering that technology to those patients?
I think it's great. From the refractive side, I've learned to under promise and over deliver. So I'll never tell a patient, that this surgery is going to get you off all your drops, guaranteed, or anything like that. What I will tell them is, there's something we can do at the time of cataract surgery that will lower your pressure. In some cases, it might even get you off your drops, but in the worst case scenario, it'll lower your pressure a couple points and give us a little more control of your glaucoma. And when you phrase it that way to the patients, it's unusual that a patient will not want it. Their next question typically is, was it covered by insurance? And we tell them yes, it is, and they're all in. And when they come in, they're excited about their vision, but their next question is, what was my pressure, doc? What was my pressure today? They want it, and we kind of underestimate how often the patients will really want it.
And are you combining then MIGs with I don't know how much femto you're doing or premium lenses? Does that all go together?
Yeah, so irregardless, if the patient has a premium lens or not, they get the same discussion if they have glaucoma about how we can manage it. And I have a little bit of an algorithm to help me decide what kind of MIGS procedure to perform, but I also give the patient options to some extent. You don't want to overwhelm them; they're already deciding between the different lenses. Now you're going to talk to them about different MIGS procedures. Most of the time they'll say, I don't know, doc. You tell me what I should have done. I trust you. And so, again, if if you know what you're doing, it's a no-brainer. And I'm actually really surprised by how many doctors today are not doing MIGS, and how many are even not doing premium lenses. Even a toric lens a lot of doctors are still reluctant to implant. And there are patients out there that really want it. And I've seen them too for second opinions, and they'll say, my doctor never offered me these lenses. And they're still out there, they don't believe in them, and I can understand maybe they were burned in the past by previous iterations of multifocal lenses that had lots of side effects. And it's not to say that the lenses today don't have some adverse effects, but the percentages of them are so low now and the patient satisfactions are so high that I think more and more doctors are slowly starting to get into them. Certainly the younger physicians, those coming out of training, are more in tune to this. They're more in tune to the desires of patients to want to have spectacle independence. I think the next generation of cataract patients that we're seeing are desiring spectacle independence more than the prior generation. And so we need to, meet those needs. And last thing you want to do, getting back to your earlier question, is put let's say a PanOptix lens in a patient and get them 20/20 J1 plus, but they're miserable because they're uncomfortable and they're saying, I should have never had that cataract surgery. Meanwhile, they're on 2 or 3 glaucoma drops and they have a terrible ocular surface. So again, if you can, treat all diseases of the eye, especially if you can do it at one time, it really benefits both patient and doctor.
It's fascinating because my concern is always that I'm going to leave out the conversation about the premium lens or, addressing astigmatism. But I think they're very similar conversations. And, you may be an expert at one or the other, but, the patient is just a patient and they have, needs for both of those things. And just as a glaucoma specialist, I shouldn't avoid addressing astigmatism or talking about presbyopia correction, whether I'm into it or not. I have to talk about it. It's sort of the same with cataract and MIGS. And I do have some high volume colleagues where they'll, see 40 cataracts on the schedule and no MIGS. And, I can't help but thinking, there's got to be 1 or 2 patients in there who would benefit. Now, I wanted to ask you about going the next level on MIGS. And, we know, I know you're a Zen surgeon. And I think we all, those of us in glaucoma, again, I think feel that it's a very safe surgery and that it's something that should be pretty widely adopted, but not everyone's felt comfortable doing it. So tell me, your approach, how you made that decision, and maybe some advice you might have for other people thinking about it.
Yeah, absolutely. So for me, I had no interest in doing Zen. As soon as I heard the word bleb, I was out. I was checked out. I said, I don't want to do this. That's already too much. I loved, it was just around the time that CyPass had gotten pulled off the market. I loved CyPass. I was getting great outcomes with them. And I was experiencing truly getting patients off of their drops and super high satisfaction. So I still wanted that, but none of the other MIGs I felt could really deliver that great an IOP drop. And Zen came around. And I was actually fortunate in that I was invited to go with select surgeons down to Panama to use it and plant it. And so I went down with several other of our good friends and colleagues and was able to implant it. And very quickly after implanting it, had sort of an aha moment that this was really not as challenging as, let's say, a Bearvelt or Ahmed, where you're dissecting the muscles and it's a lot less steps. Not to say that it doesn't require a learning curve, but the learning curve is a lot less steep. And in terms of management, there's a lot less sort of tinkering you have to do afterwards. With your trabs, you're doing laser suture lysis and you're getting hypotony, or your tubes, you're getting hypertensive phases, et cetera. Maybe you're putting little holes in your tube or something to try to affect it. You don't do any of that with this. And then you just stick it in and you leave it, and there's nothing else you have to do with it, with the one exception that you might have to needle the bleb. And again, for a cornea surgeon that's never needled a bleb, that was also a concern until I did it. And then once I did it, I said, okay, well, that's actually not bad at all. It's pretty straightforward. And talking to our colleagues like Arsham Shabani, who was telling me, listen, you want to go into a Zen and you're nervous about doing a needle, send it to me. I would love it if my whole clinic was full of patients that already had this implanted and I just had to needle them. Like it's straightforward and I'm more than happy to do it. And so pretty soon after I got back to Florida, unfortunately, Florida was one of the last states in the country to have this approved. So I got 10 Zens from the company to use to fill in and sort of sample until they got the approval. I blew through those stents in just a couple of weeks. I mean, it was really incredible how many patients I found in my clinic that could benefit from it, who wanted it, who were uncontrolled, or simultaneously undergoing cataract surgery and were progressing. And the results really spoke for themselves. We're getting pressures in the low teens off all their drops, and it didn't really matter what their preoperative IOP was or how many drops they were on. They all sort of seemed to get to that same intraocular pressure level, which may not be low enough for some patients, but for the bulk of my patients, works just great. And again, to maintain them is not hard. The way I've kind of discussed it with the patient, which I think is a key to success, is again carrying over some of those refractive ideas. Is I'll just tell the patient it's a 2-part procedure. We're going to implant the stent, and then about a month later, maybe a little earlier later, we'll do a little revision of it just to get the pressure exactly where you need it. So at 3 weeks, 4 weeks, 5 weeks, if they've got a little fibrosis, I can do the needle, and it's an expectation, not a complication. The reality is it's this very small percentage that I have to needle, but at the same time, and I don't call it needling either, but it's a small percentage I have to do, but those that I do are expecting it. And so it's not a big deal. And I think it's the same thing, you have to treat it like PCO, patient comes in with PCO, you say, not a big deal. 1 in 3 patients get this. We'll do a quick little procedure and you'll be fine. It's really the same thing with Zen, about 1 in 3 patients can get fibrosis according to the studies. I found it's less, but if you present it that way, it's not a big deal. And I think some of it has to do with technique too. We're obviously talking about ab interno, ab externo, trans-conj. There's a lot of different ways you can do it now, and there are great videos out there, but there's lots of little nuances to the technique that I think improve success rates as well, including your videos.
Yeah, I got a few videos on YouTube. That's phenomenal. And do you do most of yours with cataract surgery or on their own?
So as far as the MIGS procedures, I primarily do all of them in conjunction with cataract surgery. Zen would be the one exception that I'll do as a standalone procedure. And primarily I'm doing it in pseudophakic patients, although I have done it in a handful of phakic patients as well. And it's been great. Again, I've had some patients that come in that need surgery that aren't doing well, and you can't get them in, or you call in next availables in 2 months and they can't hang out at that pressure for so long. So we can make phone calls and beg to get them in, which is what we were doing before. But this really takes that strain off both us and the, doctor we're referring to.
Yep. And I'm sure those referring doctors are happy for the help. It's certainly how I feel, about those around me. And one of the things you said, as we wrap up here is, that you take some of the principles you learned from refractive surgery, setting expectations, and just apply that to managing glaucoma. And that's kind of the whole point of this project, which is that if you're a cataract surgeon, if you're, a great glaucoma specialist, or if you're fantastic at managing dry eye, you probably have a lot of tools that are applicable to all these different fields, and bringing them together with an eye towards adopting new technologies, all in service of your patients who have all these problems. They're all common. It's sort of what we're all about.
Absolutely. I think, it's time everyone kind of takes a step back and looks at the whole eye, regardless of your specialty. We're too used to this mindset of, oh, you've got this muscle imbalance, go see the peds doctor. Oh, you've got glaucoma, go see the glaucoma guy. Oh, you've got, go see retina. And patients are getting bounced around all the time. And especially in this COVID environment, we're trying to limit exposures. If you can kind of step back and see everything and figure out how best you can serve as much as you can, you're really helping the patient and just in general, everybody else as well.
Agreed. And David, I will thank you for joining us here.
It's my pleasure.
All right. And on behalf of Interventional Mindset, thank you very much for watching. Have a good night.